Good evening from New York for those of you listening, and I want to thank those of you listening for logging on to this webcast, and it is certainly my hope and desire that you find this an interesting and informative presentation. Before I begin, I'd like to tell you just a little bit about myself. I've been practicing dentistry in Huntington, New York, which is just about an hour or so from Manhattan, since 1981. And I was very fortunate, I would say even privileged, in having had the opportunity to work alongside my father, who was a practicing dentist for over 50 years. And at this point in my career, I would say about 80% of my clinical practice is devoted to prosthetic and elective cosmetic dental services. One of my hobbies, indeed one of my passions, especially when I had more free time than I currently do, is astrophotography. And this is a photograph I took many years ago of the great nebula in the constellation of Orion. Some of you may have heard me speak before on materials and adhesive dentistry, and certainly adhesive dentistry is an area we all need to be knowledgeable, comfortable, and proficient in, because the fact is the longevity and predictability of many current restorative procedures is wholly predicated on our ability to bond or stick various materials to the tooth tissues. And I have been very fortunate in being able to work and research alongside many of the pioneers in this particular field. Indeed, my primary mentor in adhesive technology was a great man, a colleague, and a very close personal friend by the name of John Gwinnett. And I mention John every time that I speak. And John was considered to be one of the finest dental researchers in the world, and he made major contributions to both the art and science of dentistry. And I'd be totally remiss if I also didn't mention the brilliant Dr. Byung Suh, another of my teachers and mentors, and a man who I've had the privilege of studying and researching with on many occasions. And while I personally still do a fair amount of research, and I try to conduct at least a few independent research projects each year, I want you to know, and I think it's very important that those of you listening know, that I make my money the same way that all of you do, and that is in the practice of clinical dentistry. And while I have been hired as an independent speaker and consultant by many dental industries and organizations, I have no vested interest in any of them. I do not work for any dental manufacturer. I do not sell or endorse any dental product for profit. I don't get paid for the research that I do. I make my money in the practice of clinical dentistry just like all of you do. I have the same headaches and problems that all of you have. I have a very busy practice, and fundamentally I'm interested in what works, what lasts, and what makes sense to me. And what we're going to discuss this evening, at least it's this evening in New York, in the very limited time that we have, is various aspects of directly placed composite restorations. We're going to talk a little bit about adhesives, and I suspect we might digress into some other areas as well. Now, the problem that I have is that this is actually a full-day program, and I certainly won't be able to cover everything in the hour or so that we have, but I hope to touch on at least some of the salient points and nuances of adhesive and composite dentistry. And a lot of what I'm going to be talking about this evening is the making of choices. And as dentists, we are making dozens, sometimes hundreds of treatment choices each and every day. And sometimes, just like a kid in a candy store, it's not easy knowing what to choose. And this is true whether we're doing a simple one-tooth composite restoration, like we'll be discussing this evening, or a complex full mouth reconstruction. And while there might be a number of material choices and treatment modalities that will work for any particular case, our choices, whenever possible, should be based on the best current available research, our own personal clinical experiences, the clinical experiences of others, and of course then the specific needs and requirements of our patients. In other words, our treatment choices, whenever possible, should be evidence-based. And listed on this slide are at least some of the choices we need to consider when we're going to go ahead and place a direct composite restoration. I've always enjoyed this particular quote by Dr. Harold Lowe. The first time a restoration is placed in a tooth, the life of that tooth is changed forever. The point is, we owe it to our patients to think long and hard before deciding on a definitive restoration, and once a decision is made as to what to do, we are obligated to be proficient at its implementation. And as patient demand for restorative dentistry of this nature continues to increase, and I suspect that it will, and materials continue to improve, and I certainly hope that happens as well, it is incumbent on all of us to master the clinical skills necessary to deliver dentistry of this nature. And we have more choices than ever before in selecting a directly placed tooth-colored restorative material. We have the classic composites that, as we all know, can be subdivided into macrofilled, microfilled, and hybrid materials depending on their average fill or particle sizes. We have what I like to call the confused composites, which largely for marketing purposes have been given rather exotic names like vitroids and ceramers. We have comprimers, which I am not a particular fan of, represented by products such as Diract and Compoglass. And of course, resin-modified glass ionomer restoratives with some representative products listed here. Now, whatever material is selected, the actual linkage between the tooth tissues and the restorative material is of course mediated through the use of dentin adhesives. Now, the one caveat to that is resin-modified glass ionomer restoratives, which do not use a separately placed dentin bonding agent, but typically do require the use of a separate polyacid conditioner or primer of some type. And with this virtual explosion of tooth color materials, and I haven't even mentioned indirect materials, some of which are listed in this slide here, we might ask, where does this leave amalgam as a viable restorative? And if you want to start a heated debate amongst a group of dentists, then certainly this is one of the subjects to broach. And I have heard very reasonable and intelligent individuals argue quite passionately and convincingly on both sides of this particular issue. The American Dental Association position on amalgam is crystal clear. Scientific studies indicate dental amalgam is a safe, effective cavity-filling material for children and adults. Now, that may or may not be true, but it really doesn't matter. And it doesn't matter because, safe or not, ultimately it will be our patients, not the ADA, that determines the fate of dental amalgam. And the reality that we live in today is that many, if not most patients, will no longer accept amalgam restorations. In fact, according to surveys, at this time, more than 2/3 of all direct restorations being placed in the United States are in fact direct composite restorations. These surveys are actually a couple of years old, and I suspect it's even higher than that now. I know it's much higher than that in Europe, where the use of amalgam is outright banned in several countries. And then we might ask ourselves, are composites really that much safer than amalgam? I think that's an open question that no one really talks that much about. In December of 2012, just about a year ago, the Journal of the American Dental Association published an interesting study that found that placement of resin-based composite restorations was associated with detectable increases in saliva and urinary BPA, that's an acronym for bisphenol A, and other monomers found in composites. Now, interestingly enough, the use of a rubber dam did not reduce the absorption of BPA or these other monomers, which probably means that any absorption that took place after the rubber dam was removed and the restorations were finished, and not during actual placement. Now, I personally found this study very, very interesting because, to the best of my knowledge, bisphenol A has not been used as a standalone ingredient in any composite or adhesive formulation for many, many years. It was in some materials many years ago, but it hasn't been used for many years. So the question is, how did they find it in this particular study? Well, I suspect that even though bisphenol A is not used as a standalone ingredient in composite and adhesive formulation, it is used in the synthesis of bis-GMA and other monomers that are commonly used in composite manufacture. And it is certainly possible that trace amounts of unreacted bisphenol A remained, and/or there was enzymatic breakdown of some of these larger monomers over time, breaking them down into their constituent components, including bisphenol A. Now, is this a potential health risk to our patients? And for those of you who may not be aware, bisphenol A is an endocrine disruptor, and it has been implicated in some studies to contribute to breast cancer. And is it a health risk? I have no idea for sure, but I suspect not in the trace amounts reported in these studies. And in some cases here, we're talking about billionths of a percent. The ADA position on this particular issue is this. Based on current research, the ADA agrees with authoritative government agencies that the low level of BPA exposure that may result from dental sealants and composite poses no known health threat. Well, I certainly hope that's true, but don't be surprised if you hear this issue mentioned by some of your patients. Some of you may have already experienced that. I have with a couple of my patients. In any case, the focus of our discussion today will be on composites and composite-like materials. And we're going to explore them in ways and to a degree that you probably haven't before. I'll be presenting a lot of new information here today, some of which is controversial, some of which is still unclear, and much of which really needs to be further researched before we should be making definitive treatment recommendations. So with that backdrop in mind, let's begin our journey not just into the how, but into the why of composite and adhesive dentistry. And if we're going to discuss composites, I think we need to have some idea of just what a composite is. So we're going to get just a little bit technical for the first 5 or 10 minutes of this presentation, and then move on to actual clinical application. So let's begin by making a dental composite, and this is something we're going to do together right now. Well, to make a composite, we first need some resin. As a matter of fact, let's mix a blend of several different types of resins, all with different physical and chemical properties. And we'll get all these resins together and mix them in a big cauldron or pot, and we'll kind of pour them in and stir them all together. Then into this resin soup, so to speak, we're going to add some inorganic filler particles, ground up sand and glass, if you will. So we'll add that to our resin mix and kind of stir that together. Something to give it the appropriate color, metal oxides of some type. Then something to make it get hard when we want it to, initiators of some type, and presto, we have a simple composite material. And as we all know, composites can be manufactured with different average filler particle sizes depending on just how and where we plan to use them. As a broad generalization, larger particle, more heavily filled materials are stronger with better physical properties, while smaller particle composites such as microfills aren't as strong, but they do tend to wear and polish better. Nanofilled composites, which represent the latest evolution in composite technology, are designed, in theory at least, to have both optimal physical properties and yet still be highly polishable, and hopefully hold that polish over time. I've sort of pigeonholed some composite materials into their various classification categories, as you hopefully can see on this slide. And in fact, we can simplify this slide, as macrofills and macrohybrids have been largely phased out, leaving us now more or less with 3 classification categories. And while most manufacturers now claim to have nanocomposites, the only true nanocomposite materials I am aware of, and by that I mean all the filler particles are in fact nanoparticles, are the ones you see listed down here under nanofilled composites. Now, I'm not saying that's a good thing or a bad thing, or that these composites down here are better than these composites up here. It's just that most of these other so-called nanocomposites are in fact a mixture of larger ground glass particles that are typically found in composite formulations and then chemically synthesized nanoparticles. And what most manufacturers have now done, especially since the term nanocomposite has become such a marketing buzzword, is to take their pre-existing microhybrid, whatever that might be, throw in some nanofilled particles, and then presto, we'll suddenly have a nanofilled material. And as a group, these are called nanohybrid composites. And most composites today probably fall into this classification category, where basically they're microhybrids with some nanoparticles thrown in. And this is a scanning electron micrograph of a very typical nanohybrid composite material, and you can actually see some of these larger ground glass particles here mixed in with a bunch of much smaller nanoparticles. We can contrast that with a true nanocomposite, once again meaning all the filler particles are in fact nanoparticles, something like Filtech Supreme Ultra. And in the case of Filtech Supreme, all these nanoparticles are produced via a proprietary and very secretive sol gel process. Some are coated with a silane coupling agents, others are mixed with zirconia and formed into clusters through an agglomeration process. These particles are then mixed with various resins, and here we have an SEM of the finished composite material, consisting of nanoparticles that provide high polishability, and these big, as you can see, large clusters of nanoparticles that help provide overall assembly strength. This is actually a very, very nice material, and is probably the go-to composite that I'm using most often in my practice today. But the fact is, most composites still use significant amounts of ground glass in their formulations. And this is what some of these glass filler particles typically look like under a scanning electron microscope. They come in various shapes and sizes, and they're generally made of ground silicate glasses of some type. Barium silicate is particularly popular today because it's relatively easy to produce. There's very nice physical properties, and has a nice radio opacity, so it's easy to see on an X-ray. Most composites contain some amount of fumed silica as well. This improves the handling characteristics of these composite materials and helps prevent these larger particles from kind of settling out. But if we look at all these particles, essentially they look like a bunch of little rocks or pebbles. We now need something to hold all these little rocks and pebbles together, and of course we hold them together with resins. And virtually all composites in the marketplace today still employ either bis-GMA, synthesized by Ray Bowen way back in 1962, or urethane dimethacrylate as their primary resins, or sometimes slight variations of these. And these are typically thinned out with lower molecular weight resins such as Tegma, triethylene glycol dimethacrylate, that is. or other proprietary resins that thin these out a little bit. Methyl methacrylate, which is not used in composite manufacture, is shown here just as a basis of comparison. Two things you need to be aware of regarding all resins that are used in composite dentistry today. One is that they all shrink to some degree during polymerization, and two, as polymers, they all absorb water to some degree. Neither of these are desirable physical properties and contribute to some of the problems that are often associated with direct composite restorations. And control of shrinkage stress and the problems that we often associate with shrinkage stress, some of which are depicted in this illustration that hopefully you can see, has really driven manufacturers to work towards developing some low shrinkage composite materials. And the fact is, we now do have some very low shrinkage composites, many around down around 2% volumetric shrinkage, or some even much lower than that. But I think, and actually this is an advertisement I saw just recently, I think it was in Dentistry Today or something like that, but they stated our new composite has minimal shrinkage and therefore generates less stress than other top brands. Well, that sounds good, and maybe we should all go out and buy some of that stuff. But I think we all need to be very, very careful, because as good as that sounds, we need to understand something. Low shrinkage in a composite does not necessarily mean less stress is transferred to the adhesive interface. Photopolymerization is a very, very complex, and many other factors, some of which we see listed down here, also have a very profound effect on polymerization shrinkage stress development. And it is very, very possible, by the way, to have a composite that shrinks less than another, but still induce more stress at the adhesive interface because of all these other factors. As a very quick example, we can look at some composite materials here. These are all flowables in yellow on the right, and more heavily filled composite materials here on the left. And if you were all here, I would ask you a question. That question would be, why do flowables generally shrink more than their more heavily filled cousins? And the answer, of course, is they have more resin content relative to the more heavily filled materials. And it's the resin that actually does the shrinking. The filler particles don't shrink. It's the resin that actually shrinks. So all other things being equal, the more resin in a composite, the more shrinkage is a factor. And the thing I might ask you, if we look at these composites here on the left, which of these composites, if we go ahead and place it, let's say we've used Z100 in a Class 1 composite restoration, we put it in there, we polymerize it, and we take an identical Class 1 restoration and we put Solitaire in there and we polymerize that using the same light at the same energy, and both of those materials shrink, which one do you think induces more stress at the adhesive interface? Well, most people would say Solitaire because it shrinks the most, where in fact the answer is Z100, and it's not even close. Now, how can the composite that shrinks the least induce the most stress? Well, in the case of something like Z100, it probably mostly has to do with modulus, which is a measurement of the relative stiffness of a material. A high modulus material is not very bendable or pliable, while a low modulus material is. The Z100 is a very high modulus, it's very stiff, very little give to it, and that fact alone causes it to induce more stress at the adhesive interface when it cures. So be very skeptical of manufacturers' claims regarding shrinkage stress in composite materials. And by the way, there's a very, very interesting and very easy way to make any composite low stress. I can go into any of your offices, you can show me what your composite that you're using, and I can show you in 10 seconds how to make it induce less stress at the adhesive interface. How do you do that? You just don't cure it very well, because the degree of polymerization conversion will have a direct effect on polymerization shrinkage stress. And it's almost a linear relationship. So it's very important when you're looking at reported shrinkage stress values, it's also important to ask what is the degree of conversion. And of course, in theory, the higher degree of conversion, the better the physical properties of the composite material. Now, I don't want everybody to freak out by looking at a couple of monomers that I just drew up here. And I just want you to all be aware, and it's a very simple concept, that all composite polymerization is predicated on methacrylate chemistry. That's what all these terminal groups are here, 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 and here, at the end here. It's the reason our composite resin materials shrink when they polymerize. All of these molecules you see here are called monomers, and these monomers line up adjacent to one another, and when they react with one another, they do that by the double bonds in the methacrylate groups actually opening up and forming new bonds. As these new bonds are formed, the individual molecules are actually pulled closer together. And this, by the way, is called free radical addition polymerization. So here we have our composite material comprised of our filler particles and our resins. Now, how do we make it all get hard? That is, to polymerize. Well, in the case of light-cured composites, we do this by infusing this mixture with highly energetic light photons. And that's just a really fancy way of saying we zap it with our bonding lights. And when we zap it with our bonding lights, energy in the form of photons enters into the body of the composite, and these photons interact with a light-sensitive molecule, usually, but not always, a photoinitiator called camphorquinone. And this camphorquinone then in turn interacts with a tertiary amine of some type to generate something called free radicals. Now, what are free radicals? Free radicals are atoms or molecules that contain unpaired electrons. Electrons don't like to be unpaired. They always travel in twos. And when they're alone, they're very unhappy, very unstable, and very reactive. And what they do is they desperately look for another electron to hook up somewhere within the body of this composite material. And what they actually wind up doing is stealing an electron from the carbon double bonds and the methacrylate groups that we saw in the previous slide. And again, this initiates the polymerization process, and once again, it's called free radical addition polymerization. Now here we have a scanning electron microscope graph of a polymerized composite. We can actually see these filler particles here essentially surrounded, if you will, and encapsulated by a sea of polymerized resin. And these filler particles are typically silanated. Silane is a coupling agent between inorganics, which are the filler particles, and organics, the resin matrix. And this is what the surface of a newly placed composite might look like, and here's what that same surface might look like after some time in function, maybe after a couple of years in function. And this, by the way, is a primary reason that composites wear. The resin, which is much softer than the filler particles, wears to a much greater extent, and after time the filler particles begin to stick up out of the resin matrix, as we see here, and can be lost or plucked out of the resin matrix, resulting in a hole or void. Smaller particle composites and nanofilled type composites tend to wear less than larger particle composites simply because they present a smoother external surface and they're less prone to this plucking phenomena, and if a particle is lost, the hole left behind is that much smaller. So now that we've talked a little bit about the chemistry of composite materials, let's go ahead and actually talk about placing some composite materials. I just want to briefly touch on the importance of isolation. Isolation, as you know, is important in any restorative procedure, but I think it's absolutely essential when we're doing any type of adhesive procedure. Many of the primers and adhesives that we use in adhesive dentistry are very sensitive to blood and or water contamination. So I like to use a rubber dam whenever it's practical to do so. I think it actually saves you a lot of time. The other thing I want to mention briefly is magnification and the importance of magnification. I personally do not believe it's possible to do excellent dentistry without magnification. I think it's very difficult to do even good dentistry without magnification. And for those of you listening who are not using magnification, if you don't get anything else out of this presentation this evening, the one thing you all need to do is go out and buy yourself a pair of good loupes. And there's many, many different ones out there. I have 2 or 3 different types that I use. Oroscopic designs for Visins, and there's some other manufacturers out there as well. But invest in a good pair of loupes. The other thing I want to mention is caries detecting solutions. I'd be very curious to know how many of you are actually using these on a routine basis. And I actually have mixed feelings about them. For one thing, they cannot tell you with 100% accuracy that all the caries is there or removed. But having said that, I do think they're very useful adjuncts, and I use them quite often in my practice. They'll have basically the same chemistry, by the way, which is propylene glycol in combination with various dye solutions. And the theory behind these caries detecting solutions is this. In theory, they're supposed to stain only the infected dentin, that is dentin that has been infiltrated by bacteria, is irreparably damaged, and cannot be remineralized. So it stains it, we go ahead and remove that. In theory, it does not stain affected dentin. That is dentin that is free from bacteria. It is demineralized, but has a potential for remineralization. So now I know it's commonly taught that it's okay to leave in affected dentin, and we can go ahead and do that. But one thing you do need to be aware of if you're going to do that, when you go ahead and put a dentin bonding agent on top of that affected dentin, you always get a compromised bond strength. There's many, many studies to show that. So yes, you can leave in affected dentin, but you can't bond as well to it. I personally like to make sure I really have a good, clean, fresh two-surface before an adhesive procedure. Anyway, at some point we're going to have a preparation that looks something like this, whatever your methodology is to get it to this point. We've hopefully removed all the caries. In this case we have a class 1 restoration. We're going to go ahead and restore that. Now we have to make some clinical decisions and some choices. Do we want to use a total etch system? Do we want to use a self-etching system? Do we want to use a resin-modified glass ionomer liner or a flowable prior to or in conjunction with one of those systems? And what about these new materials, these so-called bioactive materials, which are usually calcium silicates of one type or another? Materials like biodentin, and something that's get a lot of buzz and play right now is a product called Ferrocal by Bisco. Well, the fact is many, in fact most, dentists do use either a flowable composite or a resin-modified glass ionomer liner under their composite restorations. In fact, according to a fairly recent 3M survey, about 70%, or almost 3/4 of dentists, are using one or another. The difference between them, by the way, the resin-modified glass ionomer liner should be placed prior to placing the dentin bonding agent, while a flowable composite should be placed after the dentin bonding agent is placed. Why use a flowable or resin-modified glass ionomer liner? Well, there's many reasons given, but in my mind, probably the best reason for using either one of these has to do with wetting, because it's really all about wetting. When we go ahead and instrument and cut our cavity preparations and it looks smooth to our eyes, if we take that same preparation and look at it under a light microscope, it wouldn't be smooth. We'd see all these types of irregularities and voids and pits and so forth are all around our preparation. And I'm not so sure if we now go ahead and place a fairly heavily filled composite material on top of that, we can actually get into all those little nooks and crannies. So it seems to make some empirical sense if we use a low modulus or very flowable material like a resin-modified glass ionomer liner or a flowable composite, that we can better wet and get into all those little interfaces in there. Then we can go ahead and place our more heavily filled materials on top of that. And there's another potential reason that flowables and resin-modified glass ionomers may have a clinical benefit, although this is somewhat controversial. It has to do with a modulus of elasticity. Meaning, in a sense, and again, I like to use this backboard analogy. Very rarely now do you see NBA players going up and doing a dunk and the plexiglass backboard shattering into a million people. That used to be quite common. And how they stopped that, they sandwiched some type of spring mechanism between the stiff rim and the stiff plexiglass. Essentially what they did was they sandwiched a low modulus material between two high modulus materials to attenuate stress. And many think that same phenomena may occur in our composite restorations, where we're putting a low modulus flowable material in there, which may help attenuate shrinkage stress as well as functional stress over time. Although that is controversial, there are some studies that show that it may have some merit. I'm citing one right here. In this particular study, the author found an interface stress reduction of 2%, which is not clinically significant, to 19%, which probably is clinically significant, when a flowable was placed and cured prior to the placement of a more heavily filled composite material. What they found was that the results were product specific. My guess would be the lower modulus flowables performed better in this study than the more higher modulus flowables did. In any case, there's lots of flowable composites in the marketplace today. I do think some are better than others and have better properties than others. That's a whole other lecture. If you're going to use a flowable, you may want to consider using a translucent shade flowable, as in theory it should cure more easily than, let's say, like an 8.3 or an 8.4 flowable. So you might want to consider using a translucent shade. And if you're going to use a flowable, it should be placed in a thin layer and that should be placed after the dentin bonding agent is placed, covering the floor and walls with the preparation. I recommend you cure these for a minimum of 20 seconds. I'm not a big believer in rapid curing. I don't believe in a 5-second cure. I don't care what light you're using. And I don't think we'll have time to get into that, but there's a lot of good reasons why I don't think you should be using high-intensity lights for short cure times. And now we have something else. We have these so-called bulk fill light cured flowables. There's like 3 or 4 of them out right now. You can see some depicted here on the left. And the manufacturers claim that these can be placed and cured into thicker layers, and they're saying about 4 millimeters. And essentially they're serving as a dentin replacement. And so you place them maybe 3/4 up in your preparation, then you place a more heavily filled composite material over that to use as your final occlusal or enamel layer. And this is not, by the way, a new concept. This is actually a very, very old concept. And actually in the 1990s, Bisco and GC had developed products that essentially were used for this, as a dentin replacement. And they're still widely used today for that same reason. Bisfil 2B, which is a self-cured flowable hybrid composite, they're self-cured, not light-cured. And Fuji 9, which is used by many people as well, these are self-cure materials, which does make some sense because then you can use a very thick layer and be assured that it's actually going to set up. But again, this is not a new concept. Now there's a very viable and maybe even a better alternative in my mind to flowable composite liners, and that's the use of resin-modified glass ionomer liners, which I've been using for many years. And I switched from flowables to resin-modified glass ionomers because I think they're much better at controlling micro-leakage. And I believe most of our composite failures are in fact due to micro-leakage. They're not really falling out. I don't see many bulk fractures. They leak, and they get recurrent decay. And you can do a classic class 5 cavity micro-leakage test as you see depicted here, and no matter what adhesive you use, very rarely is micro-leakage a problem at the enamel margin. Very often, though, no matter what you use, very often you see a lot of leakage at this dentin and/or cementum margin. So this is a margin that we need to manage. And I'm sure all of you listening to this presentation see what I see clinically. When these composites fail, where do they fail? They fail very often in class 2s down in these deep box areas. Again, typically where you have cementum and/or dentin. That's where they seem to fail. That's where they leak. That's where they fail. So I think it's those interfaces that we need to be most concerned with. This is just, again, a restoration that I placed that failed after 20 years, which would be a clinical success. This is actually a distal of tooth number 13. The only reason you can see it now, I had to prep number 14 for a crown, and so I had unfettered visual access to the distal of this tooth. So I took a shot through the mirror, and you can see where it's failing. It's failing again at that dentin margin, which is typically where these things fail. Years ago, I set out to write a paper, and the idea behind the paper that I was going to write was to show that the best way to attenuate micro-leakage was to use a dentin bonding agent followed by a flowable composite. And after I did a literature search and some of my own research, what I found was kind of the opposite of what I was looking for. I found that study after study, it was resin-modified glass ionomer liners that did better in terms of micro-leakage than flowable dentin bonding agent combinations. And as a result of that, I kind of changed my protocol. And I'm really talking about two products that fit this classification category. One is Vitribond from 3M, and the other is Fuji Lining LC from GC America. Both of these products do very, very well in micro-leakage tests. They bond very well to dentin without using a separate dentin bonding agent. It's a very good bond to composite on the other side. They have high fluoride release, and because they have high fluoride release, they're antimicrobial. There's a good long-term track record with these materials. They've been around for quite some time now. I think Vitribond was introduced about 1990. Coefficient of thermal expansion and contraction similar to that of dentin. There are anecdotal reports of less sensitivity, although there was a recent study that I saw by Van Thompson and his group that kind of debunked that. But I don't think sensitivity is really the issue for most people. But if it is, I think one way anecdotally that you can reduce that is through the use of resin-modified glass ionomer liners. So something that I've been doing for years now, if I have a situation like this, where in this case we have kind of a deep class 1, and it's not, the pulp isn't exposed, but it's pretty deep down there. All the soft dentins have been removed, so I have good sound dentin left. Typically what I'll do is, and I like to use Vitribond, I'll go ahead and mix Vitribond, which comes either in a paste version or in a powder liquid version. I'll mix it, I'll place it with a Di-Cal applicator, and I basically cover all of the dentin more or less in a very thin layer, including I run it up the walls of my perforation. I like here for 20 seconds, and it looks something like this. So I've got this very thin resin-modified glass ionomer liner in the deep areas of my preparation. Again, I run it. I don't run it onto the enamel, but I do tend to run it covering virtually all of the dentin in a case like this. One other thing you may be able to see in the slide as you look at it here is a bevel. And I typically will bevel the enamel margin of all my composite restorations. There's a couple of reasons I do that. I think I get a much better aesthetic blend. And number two, I think you get less in terms of these white lines, these annoying white lines that we often or always see around the periphery of our composite restorations. I actually talk a lot about them in my full day presentation. Again, the difference between using a flowable, that is placed, the primer, that is placed actually after the dentin bonding agent is placed, and if you can use a resin-modified glass ionomer, that is placed prior to actually placing your dentin bonding agent. Big difference between the two. But there's many other options that you could use, I think, successfully in a case such as this. A product now that's getting a lot of play is called Theracal, which is called a bioactive material from Bisco. It's a very nice material. It's Fuji 9 a lot of people like. Biodentin is actually a very nice material as well. It's got one problem, it's got a very long set time between 10 and 13 minutes. Whereas Theracal is actually a set-on-command product. It's light curable, which makes it a lot more attractive in that regard. This is actually a case I photographed, not long ago, maybe, I just did this about a month ago, and this is a very deep class 2, I think this was actually tooth number 21, and it's a DO, and you can see it's very deep, the pulp isn't exposed, it's very deep, but if you're the restorative dentist now that's going to go ahead and restore this, you have choices to make. And all of these things, I think, could work. I don't think there's one definitive way that you have to do this. I think some dentists would not use a base or a liner, but they would go right to a dentin bonding agent. Maybe somebody that might be using sonic fill might take an approach like that. Many dentists would place a flowable composite after a dentin bonding agent. Many dentists would place a resin-modified glass ionomer liner, such as Vitrebond, before the dentin bonding agent. Or some people like to use bases like Fuji 9, or some of these bioactive materials like Theracal. What about Dical? Some dentists are still using Dical, although I think we have much better materials at this point. And then we have another choice: do we want to incrementally fill this or bulk fill this? I think these are all viable choices, and if they're done correctly, I think they all may work to some degree. And it's very hard for me to say that one is definitively better than another. My general choice at this point, though, would be to either place a resin-modified glass ionomer liner, or if it's very, very deep, or even if I have a pinpoint exposure, I probably would use a product like Theracal. Again, I just want to touch briefly on these bioactive materials, and again, you can see I put down some representative products here. It's kind of a new class of materials. They are getting a lot of buzz. I think there's some very positive attributes to these materials. Certainly MTA has been used by endodontists for many, many years to seal perforations with great success. I like this Theracal product for certain things. I do like to use it for direct pulp caps and near pulp exposures. If you're going to use it, you want to leave the dentin moist. Here's one of mine here, and I have a very small exposure here. The blood's not shooting across the room when I got this. If it was, it might be so hyperemic no matter what you do, that tooth is going to go. This is just a vital tooth, a small carious exposure. I typically like to stop the bleeding with just a saline pellet, and I just, under pressure, I just leave it there for a minute or two. That usually will stop the bleeding. Take out a little bit of Theracal, cover that over, light cure it, and then go on to the next step. As a matter of fact, very often what I will do is cover that Theracal then with a product like Vitrebond, and then go ahead with my bonding protocol from there on out. This is another example. This is by the way the fender wedge that I like to use. I like to pre-wedge my preparations. I've got it in there. I have some caries detecting solution in there. That's why it appears so red. We're going to clean that out. And again, this one was very, very deep. So again, I chose to use this Theracal product. This is a Garrison ring. If we have time, I'll show you how we use these to get to achieve hopefully good interproximal contacts and class 2 restorations. And then I'll go ahead. In this case, we're going to use a total etch technique where I first etch the enamel for about 10-15 seconds with phosphoric acid. Then I run it into my rest of my preparation for another 10 seconds or so. We'll wash that out and go ahead with our dentin bonding agent. And again, here we have the finished case. Again, that's Theracal underneath. A couple things I just want you to notice in here. One thing I'm big on, I don't feel you have to put, I do put anatomy in. I don't get crazy with accessory grooves and tertiary grooves and all that, but I do put the fundamental anatomy in there. But I do think it's very important to develop things like definitive marginal ridges. For one thing, that deflects the food towards the center of the tooth and helps it from getting trapped in the interproximal areas. I think that's very important. So, I think all of these are viable options: a resin-modified glass ionomer liner, or a flowable, or one of these new bioactive materials. I think all of those are viable options, and dentists are using these successfully in many, many cases. I can't honestly say I definitely know one is better than another. Then we have another decision to make, whether we use a base or not. Are we going to use a self-etching system, or are we going to use a total etching system? What about selective etch, where only the enamel is etched? One of the questions that we need to ask is really this: do we want to remove the smear layer using a total etch type bonding agent? And that's fine, and if we do, you just need to understand the concept of wet bonding. Or do you want to keep the smear layer, which is really a misnomer with a self-etching system? You're not really keeping it, you're modifying it, you're essentially dissolving it. You're just not washing it or the remnants away as you are with a total etch system. Proper dentin hydration is one of the keys to most total etch systems in the marketplace today, especially those systems which are acetone based. They are sensitive, more sensitive than other systems, to the hydration state of the dentin. They work extremely well as long as you understand that concept. There's actually kind of a window of opportunity where these products work best. And I like this little slider which shows, could be wet, moist, or dry. Where do they work best? Well, most total etch systems would work best on this part of the beach, where it's not wet, it's not dry, it's kind of moist. Clinically, how it should look is if you licked your thumbnail and looked at that thumbnail. That's really how the dentin should look before you go ahead and place a total etch system, if you're using a total etch technique. Now, if you've already covered that dentin with something like a resin-modified glass ionomer, this is really a non-issue, because there is no exposed dentin where you really need to worry about the whole concept of wet bonding. The take-home message for you is this. You just need to know the nuances and idiosyncrasies of whatever adhesive system you're currently using. If you're using a total etch system, then the dentin should look really like this, what you see depicted here on the right. There's a definitive moisture there on that surface. It's not puddled or pooled with water, but it is clearly moistened. Versus something like this where you can actually dry the dentin to some degree. Even with a self-etching system, I think over-drying is a bad idea, but self-etching systems are more forgiving in terms of this whole issue of wet and dry dentin. Talk a little bit about adhesive systems. And are you confused? Yeah, of course you're confused, and I'm confused as well, and I've been studying these now for over 20 years. And it's confusing because every time you feel you've got a system down and you've got the best system out there, the manufacturer of that system will introduce a new system which they say is much better than the other system, and so forth and so on. It goes on and on. When I first started studying adhesive systems, I knew the chemistry of every one cold. There was only about 10 systems to learn. Now I have a database on probably over 150 different dentin bonding systems. So yes, you're confused, I'm confused, everyone is confused. Because of the nature of this presentation, I don't have time to get in-depth into these dentin bonding agents. I just want to mention two of the newer ones that are out there that I think are kind of interesting systems, and that's the Scotch-Bond Universal System, which is 3M Systems, and the All-Bond Universal System from Bisco. And these are designed to be basically used in all etching modes. You can use them in a total etch mode, a self-etching mode, or a selective etch mode. And in theory, they work well on either wet or dry dentin, so they're trying to cover all their bases with these systems. Again, I don't want to belabor the chemistry, but if you look at the chemistry of these systems, there's a lot of similarities between these systems. As a matter of fact, the first 4 ingredients are exactly the same. Now, one system does have certain advantages over the other in some areas and vice versa, but I think these are both viable systems. What makes them viable systems is a monomer that they're using. It's called the 10-MDP monomer. It's a very magical monomer. Curare held the patent actually on this monomer for years, and they used it in all their adhesive systems. Clearfill SE bond, which I think is probably the best self-etching system in the marketplace for many, many years and still is today. What made it so good was this 10-MDP monomer. That same monomer, the patent actually ran out, and Bisco and 3M were able to synthesize it, and that's what they're actually using in the universal adhesives. And this monomer has a lot of very positive attributes. It's got a very good bond, for one thing, to metals or to zirconia. Some of you may be familiar with Z-Prime, which is a Bisco product. What makes that product work well, and it does work well, to zirconia is the fact that it's got this 10-MDP monomer in it. Very good chemical bonding to tooth tissues with this monomer as well. It's a very stable monomer as well. How I would use these two products is this. If I have significant enamel, and in this case we have some porcelain veneers we're going to be bonding on here, and hopefully if you're going to do veneers you do have a lot of enamel you want to bond to, the only way to do this, in my opinion, is total etch, because the best way to predictably bond to enamel is still total etch. So I'm going to put phosphoric acid on there, wash it off, and if I wanted to use either one of these, I would use them in a total etch mode. If I was going to use them, and here's where I might use these actually in a self-etching mode. If I don't have any enamel at all, let's say I have a situation like this where I have a crown prep with virtually no enamel, and not only that, it's a minimally retentive preparation, and I need to bond in whatever crown I'm making on this. Well, I think this would be a good indication to use either one of these products in a self-etching mode. Here's a peg lateral. Again, we prepped this for a little bit of a crown, no enamel, very little retention on this. So this would be a good indication to use either one of these products in a self-etching mode, if you're worried about sensitivity. There's no reason that you couldn't use it in a total etch mode as well. It just depends on your personal preference. And what about when you have both dentin and enamel? Say we're going to do a class 1 or a class 2 direct composite restoration. Well, that's up to you. You can use. I would not use these in a self-etching mode. In that case, I would either use a total etch or a selective etch, where just the enamel is etched, then it's washed off, and you go ahead and place it, your restoration using that type of a protocol. For those of you who may be using Clearfill SE bond, if I was using Clearfill SE bond, I would always use it only in a selective etch mode. One of the drawbacks to Clearfill SE bond is it doesn't etch enamel particularly well. So I would first etch the enamel with phosphoric acid, wash it off, and then go ahead and continue your protocol from there. No matter what adhesive system that you are using, there are certain things you can do to maximize the efficacy of that particular system. So whatever you're going to use, it has an adhesive or a primer, and you can go ahead and place that in many, many coats. It's very important then to evaporate the solvent carriers. And all adhesives in the marketplace today employ either ethanol, water, or acetone, or sometimes combinations of these as their adhesive solvents. And there's a little bit of a misnomer there. You're not drying these adhesives. I mean, you're still leaving wet resin behind. What you're really doing is evaporating or getting rid of these solvent carriers. And this is a very, very important step. because if you don't get rid of all those solvent carriers, the material will still polymerize, but the degree of conversion will be much lower because you've left in a lot of these solvents. So very, very important. By the way, the best way to get rid of all these adhesive solvents is use of warm air. And I use warm air routinely when I'm drying my adhesive preparations. Also, a very important step is to light cure the primer after you air dry it. And the one caveat to that is for some indirect restorations with some dentin adhesives, because you have to worry about film thickness. But I don't think you should be using those anyway when you're using indirect restorations. I think you should be using adhesives that you can light cure and you don't have to worry about film thickness. And there's lots of them out there. But it's also, I think, a very important step. So just realize that light curing that primer is an important step. And something I want you to think about when you go ahead to do that is how your light source is attenuated as it traverses a distance. So here, let's say we have a light that delivers only 400 milliwatts of energy, which is actually pretty low. And just remember, as that attenuates and traverses distance, in this case 10 millimeters, you lose about 50% of your light energy. And that's certainly not unrealistic in a class 2 cavity preparation where you might have a box where the floor of that box is 10 millimeters from your light source. And after we change the numbers a little bit, you can see how the numbers change. We might have a 1,000 milliwatt light source. By the time it gets to the bottom of that box, only 400 milliwatts of energy is getting down there. What does that mean? You need to leave those lights on longer. And typically we test our lights with these little testing devices you see here, and I'm just going to show you very quickly. This is one I have in my office. This is just a light I happen to have. And we tested it, and I got a reading of 814 milliwatts of energy, which is pretty good. And what happens if I back off just 10 millimeters with that exact same light and retake that test? I go from 814 to 396 milliwatts of energy. So I'm losing more than 50% of that light energy traversing a 10 millimeter distance. So I don't care how good your light is. As a matter of fact, the stronger your light, the more percentage loss that you actually get over distance. So I think we need to cure these things longer than most manufacturers are telling us. So distance makes a big difference. So watch your protocol. You don't want your light out here when you're curing your composite materials. You want it as closely and as in intimate contact as possible with the surface of that composite. I also think it's very important to cure from the interproximal when you're done placing your restorations. How many of your light tips, by the way, look like this? Again, another reason that lights can be significantly attenuated. Clean your light tips or get new ones if they're really shot up. Also, some manufacturers are irresponsible, and they really give dentists who don't know better a false sense of security by making claims like this. Our light cures most composites to a depth of 5.5 to 7.4 millimeters in only 5 seconds, and that's actually from a fairly well-known manufacturer. Well, I agree with Michael Miller. That would be great if it were only true, and it's not true. So don't believe things like that when you say it. Now we have all these bulk fill composites, supposedly, that we can cure things with, 4, 5, 6 millimeters at a shot. And I'm not so sure about that. I gotta skip this right now. I could talk a little bit about that because I want to get into another area, and that's to talk about actual interproximal contacts. I know that's a big problem for a lot of people. So let's take a class 2 like this, all right, and I like to bevel them as you see here. I put down a liner. If you're using total etch, I like to ring the enamel with phosphoric acid for 10 seconds. All right, then I'll fill the rest of the preparation for another 10 seconds, wash that off, place my dentin bonding agent, whatever it is. I like to actually use an incremental technique for most of my cases, and I use a horizontal placement technique for the dentin layers. So if the box, that might be just 1 or 2 increments depending on the depth of that box. And I'll go ahead and cure each of those separately. Then when I get to the enamel increment, that might be just 1 or 2 depending on the specifics of the preparation. But when I do that, very often I like to use a lateral technique where I'll put my first increment down and I'll actually start with a plastic instrument and I'll pull that composite towards the lingual cusps, cure it, put a little more composite, pull that towards the buccal cusps, go ahead and cure that as well. And I like to build my restorations to form. So I like to actually create my anatomy before I actually light polymerize it. I just think that minimizes the amount of finishing that you've got to do at the end. Little clinical tip to prevent your instruments from sticking to the composite. There's a product that I like called modeling resin, and Ultradent has a similar version of this. I forget the name of it right now, but it's an idea. It's a hydrophobic resin and they've got filler in it as well, so you're not diluting your composite as you are if you're using just plain unfilled resin. So I think these have a little advantages to overusing unfilled resins. These are a must for me. I spend a lot of time finishing the interproximals on my Class 2 restoration. I like the Softflex discs. You want to get the thin version. They come in the regular and the thin. You want to get Softflex thin, and they actually come in 2 diameters. This is the larger diameter, and I actually use a smaller diameter typically more often than that. Here's a finished restoration we placed here. It's a DO. You can barely see it, which is great. Not all of them look that good, but many of them do. That view is important, but this view is critically important, that X-ray view. And what you want to try to do when you do these Class 2 restorations is to avoid point or marble contacts. So you want, ideally, you want a contact area that's very broad, as you can see here, and somewhat flat. And that's about as best that I can do one. And how do you get these contacts like that? Well, as you know, it really involves the use of rings for me, for most of these rings that you see here. These are some of the earlier rings that came out. I suggest, some of you I'm sure still have these. My suggestion is you throw them out. I don't think you should use any of the first generation rings, although Jeff Bruscia would disagree with me, my friend. But I think the new rings are much, much better. And these are some of the newer rings that are out there. This is Composite type, which is one of my favorite rings, especially on premolars. That's from Garrison. These are the V3 rings from Triodent. These are probably the best rings that are out there, the most widely known. The new kid on the block is the Paladin ring from Cork, which is really just a knockoff of the V3 ring. Actually, it's manufactured by Triodent and private labeled and sold by Cork. I probably shouldn't have said that, but I did. And again, the thing to remember about all these ring systems is that separation of the teeth is not created by a wedge. It's actually created by the tension in the ring forcing the teeth apart. You still need to use wedges, but that's just to confine your composite from overflowing into the interproximal areas of your preparation. Quick clinical tip with all of these rings, basically. Don't place them like this. You can't place them down kind of straight vertically over the wedge as you see here. What you really need to do is come at an angle like you see here. It's much easier to get them in. So you would come down at an angle like this, and once you engage the wedge here, then you kind of rotate it down like you see here on top. It's just much easier to place them. I always pre-wedge my preparations, and this is actually a Class 2 we're going to do, and this is a classic here where we just have a little area of decay right here, and you can see how it's kind of blowing out inside the tooth. Pre-wedge it. I'm going to have it again. These are some of these wedges that we use. Fender wedges. The Triodent's got their own version. Lots of different things out there. I do like these wave wedges as well. I like these non-stick bands. There's lots of them out there. Lots of different shapes and forms. Proper matrix and ring placement and technique is really the key to getting good interproximal contact. So you got to be fussy. Spend a lot of time matrixing correctly. That's where you need to spend your time. If you matrix correctly, you're going to get a good contact. Again, these are the super curved sectional matrices from Triodent, which are also nice. I think you just need to play and experiment. Again, I spend a lot of time with my matrix placement. If I don't like it, I'll just take it out and get a new band and try something else. It saves me a lot of time, and I get a nice margin in doing it that way. Also, be careful when you burnish these bands, and we all do that against the adjacent tooth. Don't create a divot or create irregularities in that band, because if you do, that's exactly the surface and the interface that you'll get in your finished restoration. So again, we just want to spend a lot of time to that. Just be fussy about it. You can use 2 rings, although there's some gymnastics involved in that, and I do routinely for simultaneous for MOD preparations. And just quickly, they can be placed sometimes like that. And here's one we actually do in some of our hands-on. Sometimes you can place them opposite one another, as you see here on the left, or sometimes you have to stack them. Each case is a little different, where you're stacking one inside the other. But both of those are viable ways to do MOD preparations. It takes a little practice, but it can definitely be done. These Contact Pro instruments also are kind of useful. I do use them sometimes as well. You might want to try them. The Contact Pro 2 is fairly good. Sometimes I use them in conjunction with their sectional matrices. There are teeth you can't get a sectional matrix on, and I have to use them. I tend to use whole bands, which are 1/1000th of an inch thick. They're very thin bands. I use them very often in conjunction with a Contact Pro. Very briefly about finishing and polishing. Don't use large football-shaped diamond burrs for final anatomy. I know we all do use these things, and I think that's fine. But for my final anatomy, I like to use this is the burr that I actually like to use. You can see it's from Colting. It's an Alpen Swiss diamond from Colting. There's the number. The problem with using this one is you're going to wind up with too much of a concavity in your occlusal surface. You won't have the proper contour. This gives you a much better contour. I think these are fine initially, but I always will typically finish up with what you see there on the right. I also like some of these Raptor-type burrs, and actually I just did a hands-on for the ADA meeting down in New Orleans, and I use these occlusinators, which are relatively new from Danville Engineering, and I like these a lot. And here's one I did fairly recently, where I used the occlusinator. The only things I used, by the way, to finish this are what you see here, the occlusinator. I followed it with that Alpen Swiss diamond that I mentioned earlier, and again, there's that same diamond.
And then I just went over it with a composite finishing brush. That's it. And there was the final restoration. And again, this was Filtech Supreme Ultra, one increment, just a D2 enamel shade. It was a wide DO, and I just placed that in September. And I actually got a very nice finish, and a very nice result with just those 3 products to finish it. But there's a lot of things out there. I think you need to experiment, see what's best in your hands and with what composite system you're using. I do like these composite finishing brushes. One thing I will tell you, speed and torque matters when you're using those products. Those particular composite finishing brushes work much better with high speed and torque. And also some products do much better wet, some dry. You need to experiment with the products. I think the bottom line is I think of bonded composite as a chain, that is a series of links that form a bonded assembly. And we have to look at all these links together, and like a chain, it's only as strong as its weakest link. So we need to spend time on this. And we need this assembly strength to resist polymerization shrinkage stress, to resist micro-leakage, and withstand functional occlusal stress over time. I want to thank you for your attention. If there's any questions, I'd be happy to take them now. So anybody that's got a question can put it out there, and I'd be happy to ask it or answer it if I can. Any questions? Somebody just said, best presentation on composites. Thank you. I appreciate that. Have you tried Venus Pearl? I have not tried Venus Pearl myself. I've heard some good things about Venus Pearl, but I've not tried it. How does bond strength of resin-modified glass ionomer compare with Theracal and Biodentin? Thank you. I would say the bond strength of resin-modified glass ionomer initially is better than that of Theracal or Biodentin. Matter of fact, the initial bond strength of both of those products I don't think is particularly good. Now, having said that, over time, and that the chemistry matures with those particular systems, I think the bond strength is quite good. But initial bond strength is much better with resin-modified glass ionomer liners. I got it's a comment. Doctor, you gave so much information, we are just trying to grasp it all. Good job. Well, I thank you for that, and I apologize for speaking so quickly. It's very difficult to get as much material as I have into an hour presentation. As I said, this is actually a full-day presentation. Why do SE bonding agents work better on dry dentin? Well, I wouldn't say they work better on dry dentin. I think SE bonding agents can work on moist dentin. They have a bit broader window of opportunity. I think they actually can work on moist dentin, but they also work on dry dentin to some degree. And probably the biggest reason that SE bonding agents work better on dry dentin is because they tend to have a lot of water inherently in their formulations. So even though the dentin's dry, by using adhesive formulations that have a lot of water in them, and they usually always have to have water in them because they're acidic in nature, for that acid to work, it has to be in water. The water rehydrates the dentin to some extent, and that's the reason that with SE bonding agents they do work a little bit better on dry dentin than the typical total etch systems. Oh, another question I have is, how do you evaporate the solvent carriers with warm air? Well, what we have is actually, it's a modified hair dryer. You can actually buy these products. They're called warm air dryers. It's not like a hair dryer where it comes out at a speed like that. It's a very gentle stream of warm, dry air. There are some newer units. Some of the Cabo units, I believe, actually, or the ADAC units actually have warm air dryers built into them as well. So there are actually products you can do a search on warm air dryers, dental warm air dryers, and you will find some out there. And what we typically use actually is a 3-way air-water syringe to start, and I always follow it with warm air. Actually, warm air is very good to use for drying silane when you're silinating, say, porcelain veneers or Emax crowns, something like that. The best way, the most effective way to make silane work the best is by actually using warm air to dry it. Is microleakage a significant concern with Theracal and Biodentin? Thanks again. That's a good question. I don't know of any definitive testing that I've seen in terms of microleakage for either one of those products. Now, Theracal is designed to be used strictly as a closed sandwich technique, if you will. So in theory, it's inside the tooth anyway, so microleakage shouldn't be a problem because it's going to be covered anyway. I would say initially microleakage could be a concern, but over time these products actually integrate with the tooth tissues. They actually become part of the tooth tissues. So in theory they should leak less. But again, I don't know that I've specifically seen studies that have looked at microleakage of some of these new bioactive materials. There are so many products out there. Which one product would you recommend for etching, bonding agent, and a composite? Okay, I usually wouldn't do this, but if you pin me down and say I can only pick one composite to use for everything, at this point I would probably pick Filtek Supreme Ultra. I think it's a great composite. I like the way it looks. It takes a nice polish. It holds that polish. It's got very good physical properties. I personally like the way it's handling, so that's a matter of personal preference. There's another product that probably a lot of people haven't heard of, Estelite Omega. Sigma Estelite Omega, which is from, that's escaping me right now. That's a very nice product as well. Tokiyama, I think it is, or Tokiyumsa, or something like that. That's a nice composite material as well. As far as dent and bonding agents go out there, I think there's a lot of good ones out there. I really do. My go-to dent and bonding agent most of the time is All Bond 3. Although I'm using more and more of the Scotch Bond Universal and the All Bond Universal. I've always liked Bisco products. I've always liked 3M's adhesives. I think OptiBond is a very, very good dent and bonding agent as well. If I was going to use a self-etching system, as I mentioned before, I think Clearfill SCE Bond, hands down, is the best one. The one caveat to that is it doesn't etch enamel very well, so I would selectively etch the enamel first. And Clearfill SE Bond should not be used for indirect restorations because film thickness is a problem. But for direct restorations, I think it's a very good product. Carry solutions have negative effects on composite bond strength, and there's a question mark there. I think they probably could if you were not careful about getting it off. It's actually propylene glycol is the chemistry of most, and then they just put various dyes in there. Most caries detecting solutions. I don't know of any studies that have actually looked at that. There may be some of them out there. I don't think that should be a problem though if they're placed and washed off thoroughly. But I could see where if they weren't washed off thoroughly, potentially that might have an adverse effect on adhesive systems. So I do think it's important if you use them to actually make sure they're washed off very, very thoroughly. And if you wanted to be on the safe side even after that, you could actually take something like an intercoronal brush and some pumice and clean your preparation with that as well. Well, I want to thank you all for your time. I hope you got something out of this presentation and I didn't make you more confused than you might already have been. I hope it gave you at least one or two things to think about, maybe one or two things to try, and I wish you all the best of success with everything. It was a great meeting, and it's very hard to interact with just a computer screen with no interaction, direct interaction from the audience, but hopefully I did a good job, and I want to thank you all for attending the meeting.